Hi, my name is Rahul Bajal, and I'm one of the faculty at Baylor College of Medicine in Houston, Texas, in the United States. Today I'm going to speak to you about total intravenous anesthesia in children. I want to thank Dr. Duarte and Dr. Mota for allowing me this opportunity to speak to you today. I have no financial disclosures to report today. Hopefully, after this talk, you should be able to describe the reasons to consider TIVA in children, describe the pharmacokinetic differences between adults and children, describe different delivery models for TIVA in children, understand drugs used for TIVA in children, and finally describe the utility of EEG in TIVA for children. There are relative and absolute indications for TIVA. When we consider TIVA, we primarily consider a propofol-based anesthetic that may or may not be combined with other adjuncts such as remifentanil, ketamine, or dexmedetomidine. We can take advantage of the properties of these drugs when considering TIVA. Among the advantages of TIVA include reduced postoperative nausea and vomiting, reduced emergence delirium. Propofol anesthesia is associated with a decreased incidence of emergence delirium versus sevoflurane anesthesia, reduced airway reactivity. A 0.5 milligram per kilogram bolus of propofol has been shown to blunt airway reflexes by 50% in children, which may be beneficial in airway surgery. However, there are some absolute indications for TIVA, including susceptibility to malignant hyperthermia, susceptibility to rhabdomyolysis in children with Duchenne's or Becker's muscular dystrophy. So when we're faced with an undiagnosed floppy child who may have an undiagnosed muscular dystrophy or myopathy, it may be reasonable to consider a trigger-free anesthetic with TIVA. Among the other advantages of TIVA include improved neurophysiologic monitoring, reduced airway pollution, thereby avoiding the mutagenic effects of volatile anesthetics to the OR staff, providing an anesthetic in a remote location that may not have access to an anesthetic ventilator, providing an anesthetic while transporting from one location to another, and finally, TIVA may provide a reliable delivery of an anesthetic during airway procedures where there may be loss of a volatile anesthetic with an open airway. There are some relative and absolute contraindications to TIVA. Children with myocardial dysfunction or those with vasodilatory shock or a critical illness may not tolerate the hemodynamic sequelae of TIVA. Necessary pumps, particularly for target-controlled infusions, as we'll talk about in a moment, may not be available. Finally, children with medium-chain acyl coenzyme A dehydrogenase deficiency lack the enzyme to metabolize medium-chain triglycerides and propofol, resulting in accumulation of free fatty acids, which are associated with ventricular arrhythmias. With TIVA, there is a need for specialized pumps with algorithms for TCI. There is a greater pharmacokinetic and pharmacodynamic variability across different ages. It is difficult to estimate blood concentration in real time. As we'll talk about in a moment, the contact-sensitive half-life in children is prolonged when compared to adults. There is a need for venous access that may be challenging in anxious children or those with developmental delay. Delivery problems may go unrecognized, resulting in under-anesthetizing a patient. Depth of anesthesia monitors are unreliable in young children less than 1 year of age. And finally, there is a risk of movement and breath holding. There's a reported 30% more movement with propofol anesthesia alone compared to a sole sevoflurane anesthetic. And potentially there's 5 times more incidence of breath holding and hypoxemia with propofol alone compared to a sole sevoflurane anesthetic in children. Despite the potential advantages of TIVA, the reported use is only 10% of pediatric anesthesiologists in the UK, defined as using it weekly or more. The incidence here in the US is unknown. What else do I need to think about when considering TIVA in children? There's a need for IV access prior to induction that again may be challenging in anxious children or children with developmental delay. TCI pumps may not be readily available. And the current models for children are not validated in neonates and infants, given their altered pharmacokinetics, as we'll talk about shortly. The ability to establish a preoperative IV for an IV induction is going to be dependent on the patient and may be the most challenging part of the anesthetic. It may be challenging to obtain a preoperative IV, again, in children with preoperative anxiety, developmental delay, or behavioral disorders, or those children with a history of difficult IV access. It is appropriate to perform an inhalational induction, establish IV access, followed by conversion to TIVA, although it should be noted that transition needs to be done carefully to maintain an adequate depth of anesthesia while avoiding the negative hemodynamic effects from over-anesthetizing patients. So when using a TCI pump, this can be done by adjusting the initial TCI target and or the duration of time that the bolus is delivered. Let's briefly talk about some pharmacokinetic concepts. A drug is delivered and eliminated from a central compartment V1, as shown here, which includes the blood, brain, and liver, which is also referred to as the initial volume of distribution. The drug then distributes to and redistributes from peripheral compartments. V2, which includes the well-perfused organs, such as muscle. There is a fast distribution and redistribution between V1 and V2. V3, which includes the vessel-poor group, such as fat. There is a slow distribution and redistribution between V1 and V3. It's important to note that V1 is an artificial volume, which may actually be larger than the blood volume, particularly for drugs that are lipophilic or highly protein bound. So a drug like fentanyl, which is highly lipophilic, will have a large volume of distribution. The rate of transfer between different compartments can be described by rate constants, as shown here. Clearance is the volume of blood from which the drug is eliminated per unit time. The time required for the drug concentration to decrease by 50% is known as the elimination half-life. So prolongation of the elimination of a drug either reflects an increase in the volume of distribution in the central compartment or a reduction in clearance. It's important to note when a drug is administered intravenously at a fixed infusion rate, it takes 5 half-lives for that drug to reach a steady state concentration. When a drug is administered by infusion, it distributes from the central compartment to the peripheral compartments. Once the infusion is stopped, the drug has to redistribute back from the peripheral compartments into the central compartment to be eliminated. The half-time of the decrease in drug concentration is the contact-sensitive half-time, which can be determined by graphing the elimination half-lives against the duration of the infusion. This table shows the contact-sensitive half-time of commonly used adjuncts in TIVA, including remifentanil, sufentanil, and fentanyl. As you can see here, remifentanil has the shortest contact-sensitive half-time since it has an ester linkage that undergoes rapid hydrolysis by non-specific tissue and plasma esterases, whereas fentanyl, as shown here, has a significant contact-sensitive half-time, secondary to its lipophilicity and continued redistribution from the vessel-poor fat compartment. Propofol, as shown here in blue, despite its significant lipophilicity, also has a short contact-sensitive half-life for both short and long-duration infusions when compared to fentanyl, as shown here in red. The target concentration is the concentration desired in the plasma or at the effect site and is dependent on age, drug interactions, the surgical stimuli, and the magnitude of the desired effect. This is mathematically represented by the Hill equation, where n, as shown here, is the steepness of the slope, and that is something we can affect as anesthesiologists by either increasing the induction dose, the desired target concentration with TCI, or the infusion rate with a manual regimen, as we'll talk about in a moment. So how are kids different? The enzyme systems responsible for metabolism, along with drug clearance through the kidneys, are immature at birth and mature within the first 1 to 2 years of life. At that point, clearance is greater than that observed in older children and adolescents. It's important to note that clearance is the major determinant for drug infusion rates at steady state. Children, but not neonates, require a higher drug infusion rate expressed as either mics per kilo per minute or milligrams per kilo per hour than adults to achieve the same target concentration because of that increased clearance. Remifentanil clearance is, again, by plasma esterases, which are mature at birth. The clearance of remifentanil is therefore higher in neonates and decreases with age to reach adult levels in adolescence. Clearance is also limited by hepatic blood flow and is consequently reduced in children with low cardiac output states or those with critical illness. On the other side, volume of distribution is the major determinant of loading dose. Neonates have an increased volume of distribution secondary to increased total body water, 80% versus 60% in adults, and an increased extracellular fluid compartment, approximately 60% versus 20% in adults. So what this essentially means is that neonates and infants require a higher loading dose because of that increased volume of distribution and reduced infusion rates secondary to the decreased clearance. Finally, the cardiac output in children 1 to 3 years of age is approximately 80 to 110 milliliters per kilogram per minute, which is higher than adults. So the redistribution will be higher in healthy children from the peripheral compartments, potentially leading to a faster return to consciousness in these younger children. This is reflected here in this table, showing an increased volume of distribution with high clearance rates in young children compared to adults, again requiring increased initial loading dose and increased drug infusion rates. The most commonly used drugs in TIVA in not only adults but also children include propofol as the primary anesthetic and remifentanil, ketamine, and dexmedetomidine as adjuncts. TIVA may be delivered by target-controlled infusions or a manual regimen. TCI devices apply pharmacokinetic modeling to calculate the bolus dose and infusion rate to achieve a user-defined target plasma concentration, and these can be either open-loop or closed-loop systems. Open-loop systems require the anesthesiologist to alter the target concentration depending on the observed effect. In other words, the clinical signs of the depth of anesthesia with or without a processed EEG. Closed-loop systems, which are not available in pediatric anesthesia, automatically control the infusion rate through a feedback method, which may include a processed EEG. It's important to note that these TCI devices only predict the target concentration of the medication and do not actually measure the concentration. The rate of equilibration between the plasma and effect site depends on several factors, including the set plasma concentration on the TCI pump. So a higher set plasma concentration can accelerate the effect site concentration. With effect site targeting, the TCI calculates the optimal plasma concentration on the pump to produce the most rapid increase in effect site concentration. That's analogous to the overpressure effect with volatile agents. Unfortunately, this is not available in pediatric TCI pumps. The rate of equilibration also directly depends on cardiac output, cerebral blood flow, and rate constants. Young children, again, not only have a higher cardiac output than adults, but also have an increased cerebral blood flow compared to adults, leading to a faster rate of equilibration in young children. Rate constants, again, which can affect the rate of distribution and redistribution between compartments, are also higher in young children. Finally, lipid solubility and degree of ionization, similar to adults, can also affect the rate of equilibration between the plasma and effect site in children as well. There are two validated pediatric TCI models for propofol. There's limited pharmacokinetic models for neonates, infants, and ill children. So these two models include the PEDFuser and Catarrhea models. The PEDFuser model is validated for children 1 to 16 years of age, between 5 to 61 kilos, whereas the Catarrhea model is validated for children 3 to 16 years of age, between 15 to 61 kilos. Again, these models are not for neonates, infants, and ill children. It's important to note that these models work only on the plasma site concentration rather than the effect site concentration. Despite the limited validated models in children, TCI may be potentially more accurate than manual regimens by allowing for reduced infusion rates to obtain the desired plasma concentration. This may allow for more hemodynamic stability given the reduced infusion rates, and may also facilitate recovery time by adjustment of infusion rates based on the target concentration for return of consciousness. So what are the disadvantages of TCI? When the plasma target concentration on a TCI pump is changed, there's a long temporal delay before the concentration at the effect site equilibrates, despite some of the factors I mentioned previously. Unlike a volatile anesthetic, which can be rapidly changed. So if you want to either drive an induction or depth of anesthesia through these models, you have to set a higher target plasma concentration, which critically ill children or children with myocardial depression may not tolerate. It's important to note again that these devices only predict the target concentration of the medication and do not actually measure the concentration. It's also important to note that these models are derived from studies of relatively small numbers of healthy children, and I cannot reiterate this again, these models are not validated for neonates, obese children, or critically ill children. Unlike adult TCI models, pediatric models have no effect site prediction, and really care should be taken to confirm loss of consciousness prior to administration of either a neuromuscular blockade or insertion of an airway device. Finally, there's no commercially available pump for children younger than 1 year of age. Since these TCI models were developed in healthy, non-obese children, what do we do about overweight children given the rising rates of obesity? Again, obesity is defined as a BMI greater than the 95th percentile. Unfortunately, there's a nonlinear correlation with clearance and body weight. The induction dose should be based on the ideal body weight, which is determined by these formulas as shown here. The infusion rate should be based on allometric scaling of body weight to the 3/4 power. However, these two weights are not practical when using a TCI pump or even a manual regimen. So the rule of thumb is to use one weight by taking the ideal body weight and add 20% to account for the increased muscle mass that is present in obese patients. Are there alternatives to TCI for TIVA in children? And why would we use a manual infusion regimen? These regimens are used in countries where TCI doesn't have regulatory approval, such as here in the United States, where TCI pumps are unavailable, or when children are outside the age-weight range for the available models. Manual infusion regimens, however, only provide suggested doses and require titration to patient response. Similar to TCI, the infusion rate needs to be adjusted for such factors as pre-op anxiety, required depth of anesthesia based on the surgical stimulus, patient comorbidities such as children with critical illness or myocardial dysfunction, and whether adjuncts are being used as well. Unfortunately, frequent changes of drug infusion rates are required to maintain a constant plasma concentration with these regimens, and any desired increase in target plasma concentration, which we don't know, requires a manual bolus to be administered and the infusion rate to be increased. Any decrease in target plasma concentration, again, which we don't know, requires the infusion to potentially be switched off for a period of time and the rate reduced. Unfortunately, there are few validation studies for pediatric pharmacokinetic estimates for manual regimens. The STOR model is one such model which provides recommendations for a manual dosing regimen to maintain a plasma concentration of 3 mics per ml. It's important to note that young children require again higher infusion rates than adults to maintain the same plasma concentration given the increased clearance. And you can see the significantly high infusion rates in these young children at the beginning of this regimen to maintain that plasma concentration. But it's important to note that infants may not tolerate the vasodilatory effect and myocardial depression of the higher infusion rates given their stiff myocardium. Additionally, since clearance is reduced in neonates, infusion rates in this population should be significantly reduced at steady state, as shown here. I'm going to now transition to discuss some of the commonly used drugs in TIVA. As you know, propofol is the primary anesthetic for any TIVA technique. However, the plasma concentration for general anesthesia with propofol alone in young children is 4 to 6 mics per ml, given the increased clearance as we've talked about in young children compared to adults, where the plasma concentration for general anesthesia is much lower at 2 to 3 mics per ml. Additionally, while neonates and infants require a higher induction dose secondary to their increased volume of distribution, a bolus dose greater than 3 milligrams per kilo really should be used in caution given the increased incidence of hypotension greater than 20% described in neonates. Even though propofol is the primary anesthetic for any TIVA technique, it is a poor sole anesthetic given its minimal analgesic and neuromuscular junction effects, and often needs to be combined with adjuncts including opioids, alpha-2 agonist, ketamine, and neuromuscular blocking agents for a more complete anesthetic. So on this slide, you can see these are the model plasma concentration targets for propofol with remifentanil in children 1 to 3 years of age, showing a significant reduction for the required plasma concentration for a general anesthetic from approximately 4 to 6 mics per ml, as I previously noted, to now 3 to 4 mics per ml. However, TIVA with propofol is associated with propofol infusion syndrome, a clinical syndrome secondary to a prolonged propofol infusion. Propofol infusion syndrome is defined as a refractive bradycardia leading to asystole associated with one or more of the following clinical findings, including metabolic acidosis, rhabdomyolysis, lipemia, and fatty liver enlargement. It's speculated that it occurs in alterations in carnitine within the mitochondria, and successful survival has been reported following replacement of carnitine. The propofol dose to hopefully reduce the risk of propofol infusion syndrome should not exceed 4 milligrams per kilogram per hour for greater than 48 hours in young children, and a dose greater than 10 milligrams per kilo per hour for more than 8 hours should be used in caution in neonates. As you know, remifentanil is a pure mu receptor agonist that is a commonly used adjunct in TIVA. Its primary advantages include a fast onset and offset and a short context-sensitive halftime, as we previously mentioned. It adds a degree of smoothing even in children who require sedation only, for example, an endoscopy or colonoscopy. It attenuates the surgical stimulation response. And as I've mentioned previously, it reduces the propofol target concentration for general anesthesia. Its primary disadvantages include respiratory depression. However, a wide range of dosages are tolerated in spontaneously breathing children from 0.05 to 0.3 mics per kilo per minute, with a median tolerated dose of 0.127. But there is a large nonlinear age-related variation to preserve spontaneous ventilation in young children. So respiratory rate reduction can be utilized as a reliable pharmacodynamic marker for titrating the remifentanil infusion rate during procedures. A long-acting mu receptor agonist should be administered with remifentanil to prevent hyperalgesia. And finally, the response to a painful stimuli cannot be predicted by a processed EEG because the analgesic component of anesthesia involves subcortical autonomic responses that are not recorded by a processed EEG. So how do we dose remifentanil? Well, the Minto TCI model is for older children greater than 12 years of age and a weight greater than 30 kilograms to achieve a plasma concentration of 4 nanograms per ml, with a manual infusion regimen used for young children as noted here, with a suggested induction dose and infusion rate. It should be noted that children less than 5 years or 20 kilograms will require twice the induction bolus dose as noted here to produce the same clinical effect secondary to the increased volume of distribution in this age group. Dexmedetomidine, an alpha-2 agonist, is being increasingly used as an adjunct to TIVA. Its primary advantages include maintaining respiratory drive and airway tone, which is critical in children at risk for airway obstruction. For example, a child with an anterior mediastinal mass or an airway foreign body. It also has opioid-sparing effects and preserves neurophysiologic evoked potentials, which is critical in scoliosis surgery. and it also has neuroprotective effects, at least in laboratory studies. However, dexmedetomidine is a poor sole anesthetic. There are unfortunately no validated pediatric TCI models either alone or with propofol. However, a target concentration of 0.6 nanograms per ml is desired for sedation. A typical manual infusion regimen is noted here with an induction dose of 0.5 to 1 mics per kilo and an infusion rate of 0.3 to 1 mics per kilo per hour. One of the challenges with TIVA is depth of anesthesia assessment, so a processed EEG or a spectrogram may be used to assess depth. A patient's state of responsiveness during general anesthesia depends on multiple factors, including the inherent pharmacodynamic properties of an anesthetic agent, the effect site concentration of that agent, and the intensity of the underlying surgical stimulus. The use of EEG-guided anesthesia in children is not routine, possibly due in part to a lack of practical knowledge on how to use the processed EEG clinically. However, unintentional intraoperative awareness is more common in children than adults, with a reported estimated incidence of around 0.8%. So even though the algorithms for processed EEG are based on adult EEG data and are unreliable in children less than 1 year of age, the target in children should still be between 40 to 60. However, it should be noted that electrical interference can affect the processed EEG and produce abnormal EEG patterns, which can be secondary to a normal genetic variant, seizure disorder, cerebral hypoperfusion, hypothermia, or cerebral palsy. The anesthetic requirements in children with cognitive impairments such as developmental delay or cerebral palsy are often reduced to achieve the processed EEG target of 40 to 60. This is an example of a processed EEG from the Masimo SedLine monitor showing the depth of anesthesia here. Despite TCI and suggested manual dosing regimens, TIVA is often associated with either undersedation or oversedation given the patient's age, pharmacodynamic variability, and the degree of surgical stimulus. This particular patient was scheduled for sedation for a colonoscopy, but the processed EEG shown here revealed oversedation and general anesthesia, increasing the risk of loss of airway reflexes, hypoventilation, hypoxemia, and potentially prolonged awakening. Processed EEG in this patient would then allow adjustment of either the plasma target concentration or the manual infusion dosing. The full discussion of EEG spectrograms is beyond the scope of this talk. An EEG spectrogram carries information about the strength of different frequencies of synchronized neural activity. Time is shown on the x-axis. The power or energy of different frequencies are shown on the y-axis, which are then computed in decibels and represented by color, with blue indicating low power and red indicating high power as shown in the alpha frequency range and delta frequency range here for the various anesthetics. The advantage of monitoring the spectrogram with or without a processed depth of anesthesia index is that clinicians can directly and accurately visualize the signatures and effects of various anesthetic drugs as shown here on the patient's EEG in real time, with each drug having its unique signature. This enables them to make better clinical inferences and to titrate anesthetics more precisely, as shown here with a transition to emergence from predominantly slow-wave delta activity during general anesthesia to fast-wave gamma and beta activity with awakening. It should be noted that in children with developmental delays such as autistic spectrum disorder, there is less alpha power at the 10 to 12 Hz range and are more likely to enter burst suppression at similar propofol dosages, suggesting lower propofol requirements. Additionally, unlike adults and older children, infants lack frontal alpha predominance and coherence, so slow delta oscillations are present in infants of all ages, and theta and alpha oscillations emerge only around 4 months of age. This may explain why processed EEG monitors, such as the SedLine, are unreliable indicators of depth of anesthesia in children less than 1 year of age. I want to now describe a clinical scenario in which I would use TIVA in my practice. So I have an 8-year-old with a history of recurrent laryngeal papillomatosis who presents for direct laryngoscopy and bronchoscopy, followed by suspension microlaryngoscopy and laser treatment of those papillomas. This patient has significant preoperative anxiety from previous treatments. Given the patient's anxiety, a premedication of midazolam 1 per kilo PO is given preoperatively. Alternatively, intranasal dexmedetomidine 3 mics per kilo could also be used. The patient undergoes inhalational induction followed by an asleep IV. The patient then receives propofol 1 per kilo per bolus and dexmedetomidine 0.5 per kilo bolus. The volatile anesthetic is then converted to TIVA with separate infusions for each drug. The goal is to maintain a consistent depth of anesthesia with spontaneous ventilation and no operating room pollution by the volatile anesthetic, and avoidance of an airway device to prevent distortion of the airway during the laser treatment. Propofol is started at 200 mics per kilo per minute and titrated by the Stewart manual infusion regimen, along with dexmedetomidine at 0.5 mics per kilo per hour. Remifentanil boluses of 0.5 mics per kilo are intermittently given during the most stimulating portion of the rigid bronchoscopy. Alternatively, a remifentanil infusion could be started, which I would personally start at 0.1 mics per kilo per minute and titrate to respiratory rate. Finally, a processed EEG is used to titrate the depth of anesthesia, not only during the procedure, but to facilitate awakening as well. These are some of the common things that I routinely think about when administering TIVA in children. Inhalational induction is not a contraindication to TIVA. Propofol alone does not provide adequate surgical conditions without hemodynamic sequela and needs to be administered with other adjuncts, as we've talked about. TIVA should be used in caution in the critically ill patient and those with congenital heart disease, metabolic disorders, or abnormal lipid metabolism. And finally, processed EEG monitoring is a useful adjunct to aid in the titration of TIVA, especially for lengthy procedures and where neuromuscular blockade is indicated. Again, I want to thank Dr. Duarte and Dr. Mota for allowing me this opportunity to speak to you today.